Here, okay, this will be later. Assalamu alaikum. Good evening, ladies and gentlemen. First, I would like to thank Dr. Kazam and the organizing committee for giving me the opportunity to present our data. My name is Dr. Nidal Assad. I'm one of the cardiologists from Qatar. Also, I am one of the national coordinator of the Gulf Care Registry. Today, I'm going to basically present to you our result from the Gulf Acute Heart Failure Registry in the Arab region. And as you could see from this map, including patients from Saudi Arabia, Kuwait, Bahrain, Qatar, United Arab Emirates, Oman, and Yemen. So my disclosure, this registry was financially supported by unconditional grant from Servier, and the Saudi component was funded by Saudi Heart Association. Basically, the Gulf Care is a Gulf Heart Association project. This registry was led by Dr. Kazim Suleiman from Oman, and this was published at the Heart View in January this year. Heart View is the main journal of the Gulf Heart Association. Basically, this registry was presented at the ESC, and just a few weeks ago we had 10 abstracts, one of them an oral presentation presented at the American Heart Association. So it is multinational, multi-center, prospective, observational, hospital-based registry of patients admitted with acute heart failure with a 3 months and 12-month follow-up. There were 47 hospitals involved in this registry from 7 countries. Ethical approval was required, and the data entry was on electronic record base, and this it made it accurate not to miss information. The system will not accept final acceptance if the data is incomplete. We had a clinical trial government identifier number as shown below. So what was the inclusion criteria? The inclusion criteria was male and females above age 18 years admitted to a participating hospital from February 14th to November 13th, 2012 with admission diagnosis of acute heart failure. The exclusion criteria, patients with acute heart failure who are discharged from the emergency room without admission, or patient transferred from non-registry hospital, or failure to obtain an informed consent. So this is the Gulf Care ID number. Each patient is counted only once only. So we had this system where there is, just to avoid any duplicacy of patient, so this basically a card was given to the patient, and each patient has unique ID number. One section are kept in the consent form, one with our research coordinator in that particular hospital, and one was left on the file. So this is looking at the hospital involved in this registry. So as I indicated earlier, 47 hospitals. Out of them, 8 were university hospital, 22 were community, 15 of them were non-university teaching, and 2 of them were private hospital. So we had a blend of patients from a real life situation, basically, of our current practice in the region. Looking at availability of cath lab, 28 hospital had cath lab facility, 23 had a backup cardiac surgery, ICD, CRT implanting center, there were 18 of them, ICU or CCU facility in 44 of them, and heart failure clinic only in 14 of the 47 hospitals. So this is looking at the recruitment by countries. Most of the recruitment came from Yemen with 30%, 20% from Kingdom of Saudi Arabia, 19% from Oman, 11% from Kuwait, 8% from United Arab Emirates, 6.8% from Qatar, and 1% from Bahrain. And this roughly, it corresponds to the population size. So what are the types of acute heart failure? We have divided them into, we had a total of 5,005 patients, divided into HFpEF with a preserved ejection fraction, and the definition was taken from the ESC with ejection fraction more than 40%. We had 31% fallen in this group, whereas in the reduced ejection fraction, almost 70% were in the reduced ejection fraction group. Looking at de novo acute heart failure presenting for the first time, and we found that 45% of them did present for the first time, whereas chronic readmission were 55% of time. Looking at the median left ventricular ejection fraction, we found is 35%. So what about the demographic of our registry? We have found that the mean age is 59 years. The males were 63%, and Gulf citizen were of 83%. So looking at the mean age of acute heart failure patients, and we try to compare them with the Western registries. So we looked at ADCHF, European Heart Failure Study, and Optimized Heart Failure Study. So what we really found that our median age is 59 compared to the Western, which is 70, 72, and 73. So our heart failure patient in this region are way younger compared to the Western counterpart. So looking into analyzing the medical history, we have found that 47% of them, they do have coronary artery disease, which is opposite to my previous speaker. Valvular heart disease is only 13%, and this mainly comes from Yemen. Again, we observed that atrial fibrillation is only 12% of them had atrial fibrillation, peripheral vascular disease in 4.5%, stroke or TIA in 8%, and chronic kidney disease in 15%. The striking things here, diabetes and hypertension were really also very high. So coronary artery disease 47, diabetes is 50%, and hypertensive in 61% of those patients. Smoking in 22% and alcohol in 3.5%. So looking at the medical history, so we chosen to compare hypertension, coronary artery disease, diabetes, and atrial fibrillation, comparing our population with the Western population. So we choose the Gulf Care compared to ADCHF and European Heart Failure Survey. What we have observed in hypertension, they are, our numbers are equivalent and to the European or Western data. The coronary artery disease, we are a bit lower compared to the Western registries. However, diabetes, we have significant more diabetic heart failure patient in our population compared to the Western counterpart. And also very interesting, the atrial fibrillation. We have a way lower rate of atrial fibrillation compared to our Western counterpart. And probably this could be explained by age. Our patients' age is younger compared to, so this may be one of the factors. So looking at the clinical presentation, we observed that heart rate at presentation were 97 beats per minute, and at the time of discharge it was around 76. Systolic blood pressure 137, diastolic blood pressure 81 millimeters of mercury. And regarding clinical presentation, dyspnea, orthopnea, P&D is the commonest presenting symptom. Peripheral edema also present in 54% of the time. So what about the New York Heart Association class of admission? Majority of patients are New York class 3 and 4. And at the time of discharge from the hospital, the majority were 1 and 2. In hospital course, 9% used non-invasive ventilation, 8.5% required to be intubated, 16% were on ionotropes, 8% were in cardiogenic shock, 2% were on requiring dialysis, and 10% requiring, they had arrhythmia requiring therapy like cardioversion or device implantation. So looking at the discharge medication, so 71% of them, they were on beta blocker, 78% they were on ACE or ARB, 40% were on angiotensin antagonist, 94% were on diuretics, 25% were on digoxin, and only 5% were on ivabradine. So pre-admission and discharge medication, so we compared, so there were significant improvement on beta blocker from 57 to 78%, and angiotensin antagonist, the ACE and ARB, there has been a slight improvement in therapy delivered, but there are room to improve in this part. What is the etiology of heart failure? We have found that more than 50% of the causes of heart failure in the Gulf region is due to ischemic heart disease, whereas 18% are due to dilated cardiomyopathy, and 16% are due to hypertensive heart disease, whereas 9% are due to valvular heart disease. So what is the important question? What we ask ourselves, what is the precipitating cause of heart failure? So we analyzed our data, we found that 27% of them are because of acute coronary syndrome. The second most important, 20 or more than 20% are due to mild compliance with medication. 15% due to infection, 8% due to uncontrolled hypertension, uncontrolled arrhythmias in 7%, worsening renal failure, anemia are of smaller percentage. What is the hospital outcome? We found that 89% of our patients, they were discharged home, and the median length of hospital stay is 7 days. 6.3% died, and 1.8% were transferred to another setup, and 3% left against medical advice. So the 3 months follow-up, where we had a very good follow-up, up to 98.4% were all telephonic, and 1 year follow-up was 98.4%. 68% were telephonic, and 32 were based on clinic. Follow-up readmission, we have observed that 20% got readmitted in the first 3 months, and 42% readmitted at 1 year. and the median hospital stay of 6 days. Device therapy intervention were quite small, 1.7, 2.3, and 3.2%. Maybe because many of these centers involved did not have implant facility. Also, it may reflect also a lower implant rate in our region. Revascularization, again, we expect a higher number, where 7.4 at that in hospitalization, 12% at 3 months, and 20% at 1 year. So this is the important slide, the Gulf care mortality in hospital 6.3%, 3 months is 13%, and 1 year mortality is of 20%. So finally, these are my conclusion. Gulf Care is the first multinational, multi-center prospective registry of acute heart failure in the Arab Middle Eastern countries. Gulf Care patients are more than a decade younger than their Western counterpart, with a higher prevalence of diabetes and lower prevalence of atrial fibrillation. Ischemic heart disease is the most predominant etiology, while acute coronary syndrome and non-compliance to medication are the most common precipitating factor. There is suboptimal use of evidence-based medication and low rate of revascularization and device therapy. Mortality rates are close to those reported from the Western registries, but should be evaluated in light of the younger age of the Gulf care population. At the end, I would like to thank the GHA board member, the lead PI, Dr. Kazim Sulaiman, Haytham Amin from Bahrain, Jasim Al-Suwaidi from Qatar, Wa'il Al-Mahamid, Alawi Al-Sheikh from UAE, Ahmed Al-Mutarrib from Yemen, Mustafa Rida, Basim Bulbanat from Kuwait, Khalid Al-Habib, Hussam Al-Falih, Abdel Fattah Al-Asfar from Saudi. We have here Muhammad Al-Jarallah from Kuwait, Nushin Bazargani from United Arab Emirates. Thank you very much for listening.